So someone wanted to hear about retinal migraine, and I really actually don't like this term because I think migraine is a brain thing and not really an eye thing. I think of it as a spreading depression of electrical activity in the brain, and that means it's usually bilateral and simultaneous. When you have the aura, it's typically a jagged line, which we call a fortification scotoma, associated with a scintillation like a flashing light, and then it moves across your visual field and that's called march and buildup. So to me, the visual aura of migraine is different than what we call quote unquote retinal or ocular migraine. And I think that it's better to refer to this as retinal vasospasm rather than calling it migraine. The vasospasm is a better explanation because it's going to be unilateral and it's usually a negative phenomenon, not like the fortification scintillation scotoma of typical classic migraine aura. And so it can mimic amaurosis fugax, where they lose their vision, and sometimes it's no light perception. So in retinal vasospasm, also known as ocular migraine or optical migraine or retinal vasospasm, I prefer this term. The way to make the diagnosis is they have to have a normal eye exam, number one. You can't have anything in your eye to explain the complaint. It can't be a branch retinal artery occlusion or a central retinal artery occlusion. You might actually see the vasospasm in real time, but that's so rare to capture it during the event. And if they have migraine, great, but if they don't have migraine, you can still make the diagnosis. It has to be fully reversible and leave no permanent sequelae. And the more episodes that occur, the better. So if they've had 100 episodes or 1,000 episodes of stereotyped transient monocular vision loss in a young person, that's almost always going to be retinal vasospasm. If it's the first episode or they have less than 10 episodes, that's a dangerous time because that person needs amaurosis fugax workup, because it could be retinal vasculitis or retinal emboli or retinal thrombus. It doesn't have to be vasospasm. The question, however, was what treatment do I give these people? And the treatments are to keep a diary. Patients often have a trigger for their migraine: stress, lack of sleep, foods and drinks, super common triggers. However, we can try and use blockers. The two blockers that have been used in the literature are calcium channel blocker and beta blocker. And you can use migraine prophylactic agents or antiplatelet agent with aspirin. These are all unproven. However, anecdotally, all of them have been used. And you can see that some of the migraine therapies have been used on the prophylaxis side. So that's like amitriptyline and these other things that people use for headache syndromes. In pseudotumor cerebri, it's one of our go-tos is amitriptyline. So the bottom line is retinal vasospasm is probably what we call retinal migraine. You have to have a normal exam. Be better if they have migraine. Keep a diary, and we treat it with avoidance of the triggers and the blockers: beta blocker, calcium channel blocker.